Hello, my name is Dr. Scott Visovatti, and I am a cardiologist and assistant professor of internal medicine at the University of Michigan. And I'd like to talk a little bit about the role of exercise in the diagnosis and perhaps even predicting the future of patients with pulmonary hypertension. So what we know is that there are groups of folks who are at risk for developing pulmonary hypertension or pulmonary arterial hypertension, which is a subgroup. Those folks include patients with connective tissue disease like scleroderma or patients that have had blood clots in their lungs. Now we know not everyone with scleroderma or everyone with a blood clot in their lung will go on to develop high pressures in their lung, which can ultimately lead to right-sided heart failure and death. So obviously this is a critical issue to figure out. How do we tell a patient what the future may hold? So if I could give an example of a patient with scleroderma who comes in to see their rheumatologist or their cardiologist or their pulmonologist, and that person is concerned that their exercise status has changed. They can't do as much as they could at last visit. They're having difficulty climbing a flight of stairs or even speaking complete sentences. So typically, we would get an echocardiogram, perhaps pulmonary function tests, other studies that would accurately assess what the pressures are in the heart and in the lungs. And that's something we do with a study called a right heart catheterization, which is basically putting an IV in the side of the neck or in the groin into a vein and threading a catheter that can measure pressure up through the heart and into the main arteries of the lungs. That's the gold standard test. There are specific cutoffs that tell us whether or not a patient has pulmonary arterial hypertension based on pressures and some calculations. The difficult situation here is that sometimes we find that they don't meet criteria for pulmonary arterial hypertension, yet they're still feeling poorly, and there's always that cloud hanging over them in the sense that, great, today they don't meet the diagnosis criteria, but what does the next week or month or even year hold in store for them? Based on some work that was done at the University of California, Los Angeles by Dr. Khanna, who's a very prominent rheumatologist who we're happy to have here at Michigan, and we work very closely together, he found that exercise can basically unmask different profiles, meaning different collections of pressure data that might identify folks who are at higher risk for the development of pulmonary arterial hypertension down the line. Working with him and Dr. McLaughlin and the group here at Michigan, we started not only performing these right heart catheterizations and measuring pressures at rest, but also with exercise. So it sounds a little bizarre, but we can slide a bicycle, what we call an ergometer, on the end of the table where the patient is undergoing the heart catheterization, and they can exercise while that catheter is in place. And what we've found is that there are very distinct patterns that can emerge when folks are really pushing themselves. The exciting thing here is that we are finding sort of a middle ground between normal pressures and pressures that would be diagnostic of pulmonary arterial hypertension. And we think that this middle group, this pattern that's sort of in between those two extremes, it might predict somebody who is more likely to go on to develop this horrible disease. And so if we can identify those folks, we can follow them more closely. Our hope is that we can actually begin clinical trials to see if treating people with medications at that earlier intermediate stage would be helpful in preventing the actual development down the line of this disease. But that's something that we're working on very carefully right now. It's a hot topic and it really deserves some careful attention here. What came out of the newest World Symposium is this idea that our strict cutoff for what's abnormal, an abnormal pressure in the pulmonary artery, was perhaps a little higher than it should be. In other words, from studies that show what a normal pressure is, we know that there's sort of a range of normal and abnormal. And so what our experts in Nice found last year was that we need to perhaps lower that cutoff. So the mean pulmonary arterial pressure cutoff had been 25 millimeters of mercury, meaning up till that point, that was considered to be normal or high normal. The important thing here is that the definition also required some calculations that showed that the arteries in the lungs were clamped down about 3 times normal or greater. The new definition lowers that mean pulmonary arterial pressure threshold to 20 millimeters of mercury. So a lower cutoff there, potentially capturing more people. However, that important point is that pulmonary vascular resistance, or the degree to which the arteries are clamped down, it's still necessary that that calculation shows 3 times normal or greater. We've gone back since this new definition was put forth and looked at our past diagnoses and found that this changed categories for very few people, meaning that that would be a very unusual person that would now be included in the group of pulmonary arterial hypertension. But for that one person, that's a critical difference. That's somebody that we could now treat, whereas before it would be more difficult to justify treatment. So it's a slight difference. It doesn't really change the exercise world. And what that last World Symposium concluded is that we still really don't have enough solid clinical data, enough clinical trials to justify having a consensus definition for what the role of exercise in pulmonary arterial hypertension, which is why a lot of us who are working in this field are doubling our efforts to try to show that we do think exercise can show the middle ground that is on the spectrum leading from health to disease. What we think is also exciting here is we're growing the offerings that we have for folks with blood clots in their lungs, something called pulmonary embolism, which is a blood clot that typically breaks off from the legs and goes to the lungs. For most people, that is something that the body handles by breaking down that blood clot. For a small group of people, the body doesn't have that capability or lacks the potency necessary to completely break down all those clots. So over time, those blood clots can actually turn into scar tissue. And so what our center and others are offering is either a type of open heart surgery to surgically remove that scar tissue, or in a group of patients who aren't candidates for surgery, we are offering something called balloon pulmonary angioplasty, which is a little bit like what we offer to patients who have blockages in their coronary arteries, in that we can put a catheter in and use a balloon to move that scar tissue off to the side and help blood flow to the lungs. But like that patient with scleroderma, we first have to prove that those pressures are high enough to give that person a diagnosis of what's called chronic thromboembolic pulmonary hypertension. There are strict cutoffs in terms of pressures. And what we are finding is that we'll take a patient to the cath lab, perform that right heart catheterization, and find that those pressures don't quite meet that definition of pulmonary hypertension. But again, they're feeling poorly, they're short of breath, they can't do what they did before they had this pulmonary embolism. So how do we help them? Well, we're using exercise here as well, meaning all too often it's the case that climbing a flight of stairs or going up an incline is the thing that's most difficult for patients like this. And so we want to try to recreate for their body that same stress by exercising them and watching to see if patterns of pressures showed sort of an intermediate group who are not quite normal, but still don't meet that definition of pulmonary hypertension. And we believe that this may be a group who may require something sooner rather than later. And that something could be medication, it could be a angioplasty, or perhaps it's somebody who we need to watch all the more closely to see if surgery is in their future. So once again, using exercise as an evocative maneuver, a way to kind of put the body under a stressful situation to see if that can help us identify folks who really do need to be intervened upon earlier rather than later. My name is Scott Visovatti, and I'm aware that I'm rare.